Hello, my name is Deborah Cohen, and I am the MAVEN Project volunteer moderator. Thank you all for joining us today and our friends at Yakima Neighborhood Health Services for hosting today's session, Eating Disorders in Adolescents with Dr. Najah Musacchio. Dr. Musacchio is a board-certified pediatrician with extensive expertise in adolescent and young adult health. In academic and community-based settings. She was an attending physician in the Patuxent Family Division of Adolescent and Young Adult Medicine at Lurie Children's Hospital of Chicago and assistant professor of pediatric at Northwestern University Feinberg School of Medicine. There, she started and directed the mental health and primary care program, providing consultative care for mild to moderate anxiety, depression, and ADHD, and also educating residents. As a staff physician at Girls to Women Health and Wellness, Dr. Musacchio provided primary care and collaborative mental health care, including eating disorder treatment for girls and young women. She was also formerly the lead clinician at Uptown Teen Clinic in Chicago. And with that, Dr. Musacchio, please go ahead and share your screen.
All right. Hi, everybody. Let me share my screen. Okay, can everybody see that? Okay. All right, so I'll be talking about eating disorders in adolescents. If anybody has any questions along the way, please raise your hand or just put it in the chat, and I'll try to address them as I go. Here are some housekeeping slides. Learning objectives for today are to describe the presentation and management of eating disorders in adolescents in a primary care setting, and describe strategies for family psychoeducation regarding eating disorders. So eating disorders are very complex, serious mental and physical illnesses. And there are a lot of different types of eating disorders, but they all involve feelings, behaviors, thoughts about food, weight, and body size. They can severely limit somebody's function in life, and they are potentially fatal. There's no single cause of an eating disorder. I know a lot of people like to say like, oh, this is just because there's all this pressure to be thin on Instagram. And that might play into some people's development of an eating disorder, but the reason and how someone ends up falling into an eating disorder is very complicated, and it can vary from person to person. There might be genetics involved, or psychological conditions, and a lot of other factors. In the United States, there is about a 9% chance that we will sometime over the course of our lives develop an eating disorder. So these are really common. And that's why, given all of that, it's very important as PCPs that we identify patients as early as we can so that we can intervene aggressively in order to help support them in getting the best outcomes. And not only for patients who have an eating disorder per se, but also those who have disordered eating patterns, like who might not meet the DSM-5 criteria, but are experimenting with eating disorder behaviors or having a lot of these thoughts running through their heads. We want to make sure that we pick up on that as PCPs and address it aggressively, because that way we can help prevent this kind of snowball effect that can happen for a person. So when we're trying to understand the perspective of someone with an eating disorder, I think it's helpful to use this framework that Jenny Schaefer in her book, Life Without Ed, came up with. She had an eating disorder, she had anorexia, and I think she had bulimia too. And she talks about it in this book. And she thinks of her eating disorder as an abusive boyfriend. And she calls him Ed. So Ed and I lived together for more than 30 years. He was abusive, controlling, and he never hesitated to tell me what he thought I was doing and what I was doing it wrong, and what I should be doing it and sorry, I've never read before, and what I should be doing instead. And then Ed would say, I just want the people I haunt to blindly follow everything I say. If I can get people to isolate, I can control their lives, not just what they eat and weigh, but everything about them. I think this is useful when we are speaking to patients who have eating disorders to think about it in this way. It can be very challenging, like if you're in a family and you're bearing witness to a loved one who's in an abusive relationship, it can be very difficult to try to extract them from it. And the person in the relationship might have a lot of conflicting feelings about what's going on, where, you know, I don't like this and this hurts me, but I do like this part of it. And they can also kind of sometimes feel like they're going to leave and then later feel like they're going to stay. So it really is a similar process, I think. I'm going to run through a few myths that I'm thinking you don't believe, but just in case, these are pretty commonly held misconceptions. One myth is that you can tell by looking at someone if they have an eating disorder. And of course, that's not true. As all these people in this poster could have a serious life-threatening eating disorder. Patients who have average BMIs or above average BMIs, I think, are the most likely to slip through the cracks of a primary care office. And sometimes it's because we might not even have it in our brain to even be thinking about it. Or sometimes healthcare practitioners might actually end up facilitating an eating disorder and encouraging some of these unhealthy eating habits. Another myth is that only middle-class white girls have eating disorders, and that is not true. Anybody, any ethnicity, any gender, any age. When we're talking about adolescents, there are certain groups that have a higher risk of them: sexual minorities, trans youth, and then kids who have chronic health conditions relating to their diet. So celiac disease, insulin-dependent diabetes, for example. Okay, so moving on to diagnosis. First, anorexia nervosa involves restricted intake to the point where someone ends up with a significantly low body weight. Patients with anorexia have an intense fear of gaining weight. And they also might have altered self-perception of weight. Their weight influences their self-worth excessively. Or they have a persistent lack of acknowledgement about how serious the situation is. Amenorrhea is not required in anorexia. It used to be, but no longer. And that's not to say that anorexia does not affect periods. It absolutely can, and it commonly does. Patients might end up dropping a period, missing one here and there. Atypical anorexia occurs when someone has significant weight loss, but their BMI is normal. So this is that clinical scenario again that I think sometimes slips through the cracks in a primary care office. Over half of patients with anorexia will end up having a psychiatric disorder at some point over their lifetime, and most commonly that's depression. Anorexia has the highest mortality rate of any mental health condition. I mean, this is really an eye-opening stat. So we have to keep this in mind when we're diagnosing a patient with anorexia and talking about how serious we think this is. Patients with anorexia usually present in the teenage years. They might describe a long history before of body image concerns, like feeling like they weren't attractive or feeling like they were just didn't like their body. Patients who participate in activities that focus on appearance, and especially those that value a smaller body size, are at higher risk. So things like dance team, gymnastics, cross country. And another clinical scenario is that they might have had like some illness that ended up causing them to lose weight or not eat. Like let's say they had like a really bad stomach flu and couldn't eat well for a while. And then maybe some people started commenting like, oh, you look good. Did you lose weight? And then they kind of like fall into an eating disorder, like accidentally that way. What you might hear from families is that they've noticed that the teenagers like eating by themselves more, or when they have family meals, they say, oh, I already ate earlier. Or, going out to a restaurant, they're not eating anything. They said they already ate. And then it might get to the point where they're not even eating in restaurants anymore. They just don't go, or they're not even participating in family meals. The parents might also notice that the teenagers eating and drinking a lot of kind of weird foods that don't have any calories in them, but seem to be designed to like fill up somebody's stomach so they don't feel hungry. Another common scenario is that the teenager like was interested in healthy eating or like clean eating, which I don't like that phrase at all, but clean eating, and started let's say turn vegetarian, and then they went vegan, and then they cut out wheat and gluten. So kind of this like cascade of restriction of food types that ends up kind of getting out of control. On the other hand, bulimia involves binge eating, where the person feels like they're out of control in eating at least once a week for 3 months. And along with that, they have compensatory behavior. So strategies to either get rid of the feeling of being full and or get rid of the calories that the person just ate. And there's a number of different strategies people can use. When we say bulimia, I think people usually think about vomiting or fast or purging, but also the person might be fasting, using laxatives, exercise, diuretics, diet pills, or ADHD medications like stimulants, caffeine, and their self-image, their evaluation of themselves is also excessively influenced by their body. So people with bulimia, they have a 90% lifetime risk of having a psychiatric disorder. And usually this is depression, anxiety, substance use is more common, and personality disorder. And then suicidality is highlighted here because it's very common in patients with bulimia. And we definitely need to ask about this as part of our mental health evaluation. In one study, it showed that patients with bulimia, like half of them had had a history of suicide ideation, and a third had attempted suicide. This is sky high. Patients with bulimia might be described by their families as like, she must have a high metabolism. She's always eating. She's not gaining weight. They might have impulsive type personalities. Parents, this is a very common scenario where the parent was cleaning the room of the kid or snooping and ends up finding like a huge stash of candy or wrappers, like evidence that someone has been eating an excessive amount of junk food past the point of where someone would think like that was enjoyable. Like it's clearly excessive and it's secretive. They might also notice that the teenager is drinking a lot of liquid, like right around a meal, right after it helps make it easier to throw up, or that they're eating a lot of junk food. Like they might notice on their credit card bill that they went to 3 different, fast food places in a row, driving around doing that. The teenager might be going to the bathroom or taking a shower right after meals. And they also might be exercising at weird times, like late at night after eating. Binge eating disorder is similar, that someone is binge eating where they feel like they're out of control and they can't stop, but there's no compensatory behavior. And instead, the person with binge eating disorder kind of just like exists with this feeling of anguish and guilt and sadness. So, to meet DSM-5 criteria, they need to have at least 3 of eating more quickly, eating until uncomfortably full, when they're not hungry, and then eating alone due to embarrassment, feelings of disgust, guilt, or depression. Binge eating, it might be the most common eating disorder. There's just not a lot of data on it, although that evidence basis is growing. It seems to be associated with having a poor body image, history of dieting, emotional eating, low self-esteem, and depression and anxiety. Avoidant restrictive food intake disorder is ARFID. And this is a relatively new diagnosis, but it's getting more and more attention and more research behind it as well. But patients who have ARFID, they restrict what they're eating, but not because they're worried about their body shape or like appearance. It's for some other reason. And there can be a lot of different reasons and presentations with what's going on. But the restriction is so significant that it ends up causing significant weight loss, nutritional issues. They might need to be on supplements. They're not growing well, or it's just significantly interfering with their function. Patients with ARFID tend to present a little younger, and they might have some other psychopathology going on, like anxiety. Autistic kids are more likely to have ARFID. And they might have a history of a food allergy or intolerance, or maybe even like multiple food allergies. Maybe they had some really bad experience in the past where they had to get like an EpiPen, or were throwing up with some food reaction. And now they're coping with that by restricting what they're eating, like excessively. They may have had a food-related trauma, like maybe they were in an abusive household where they didn't have good access to food. And so this is how they're kind of coping with it now. They may have always been a picky eater, but now it's gone next level. So we're to the point of, let's say, I only want to eat a hot dog from this certain brand every single night for dinner. That's it. Nothing else. And they become neophobic. So they're phobic. They're so incredibly fearful of trying something outside of the zone of what they eat, to the point where they can be irritable and grouchy and angry at a parent trying to push them into something else. They might seem to be like hypersensitive to texture or taste, like way beyond what you would see in a typical kid that age. Saying something is like super slimy or disgusting, or I don't eat anything that is chopped up into squares, things like that. They may have a fear of choking or vomiting. Sometimes maybe if kids saw like someone throw up in the cafeteria and it really disturbed them, and now they're worried it might happen to them. So then they don't want to eat foods that might make them throw up. And then some kids with ARFID are described by their family as not being interested in eating. They're just not eaters. And that's a red flag, because that is the human condition, is like enjoying food. So hearing that should definitely set off some alarm bells. Okay, moving on to clinical evaluation. Generally speaking, as I said, this is a really varied group of eating disorders. So a lot of what I'm going to go through in terms of management might pertain more to anorexia, let's say, or some other food restriction, as opposed to the other conditions, but it'll be pretty obvious with how I'm talking about it. So managing a patient with an eating disorder can be very challenging as a PCP. There is oftentimes denial in the patient about how serious it is, like how threatening it is to their well-being, medically and psychologically. There can also be denial in the parent, and that really complicates things when the parent doesn't think that anything significant is going on, or the parent might even be like aiding and abetting the eating disorder. Ambivalence is very common, feeling like I want to get better, but I don't want to get better, and I'm too scared to get better. I can't get better, or I hate that I have to focus on this so much of my time, but I also I'm so scared I'm going to be fat, and I don't want that. Also, anger is common, anger from the patient, like you're getting in my business, like who do you think you are? You don't know what's going on with me. And then also anger between the parent and the patient too. Like the mom might be angry at the kid, like you're hiding these things. I know something's going on. Why are you doing this? There can be a lot of strong emotions. Shame is really huge with eating disorders. It's like very embarrassing to talk about a lot of this stuff. And especially in a primary care office where, you have such a short amount of time, and like, do I really feel comfortable talking about this to somebody? Like, they don't even know me. And then malnutrition. If someone is not getting the nutrition they need, the brain is just not working properly. The brain is not making good judgment calls about what to share with a PCP, And the person might not even have the energy to put into trying to some of these interventions that the PCP is recommending. Like just, I don't even have it. I can't even focus on it. I don't know. So all of this together can mean that as PCPs, we might have an incomplete or inaccurate history. We don't really know what's going on. And so we might try to rely more on objective findings like an exam, like someone's weight. But even that can be unreliable because people might be wearing big baggy clothing, multiple layers of clothing, which can make them appear to be bigger or weigh more. Or sometimes people put weights or heavy objects even in their clothing or drink a lot of water before the appointment. There can also be conflict during the visit between the PCP and the patient and the parent. And worst case is there can be disengagement. So someone can say, yeah, cool, great, and then bye. And then they don't come back. Or maybe they do come back and it's a year later when things are a lot worse. When we're taking a history for an eating disorder, we want to ask about like how they feel about their body and kind of like, when did this all start? Like, have you always felt like this? Was there something that triggered this all from starting? And you want to get a weight history. So what is their lowest weight, their highest weight? What is, if they were recently in a higher level of care for an eating disorder, you want to know what they were counseled was their goal weight, like what they're supposed to be working back up to. And if someone is not in that, has not been recently in treatment, but their weight has been declining, asking them, do they have a weight in mind, a goal weight? That is such an important question to ask because it can be very illuminating in terms of where the person's perspective is with everything. Okay, take a dietary history. So starting with yesterday, what did you eat in the morning? What did you eat at lunch? What did you eat for dinner? We know, of course, like given how complicated all this is, someone might not feel comfortable sharing everything with us, but we want to at least try to understand what's going on. And when we find out what they're eating, we want to ask about volume. So it's not enough to just say eggs, like how many eggs? So you can get an idea about caloric intake. Ask if there's anything they don't eat. And if they say no, maybe you might even need to ask some particular questions, like, do you eat chocolate? If I had a candy bar for you, would you eat it? Things like that. Do you eat wheat? Do you eat sweets, dessert? Who are you eating with? Do you ever eat alone? And where are you eating? Are you eating in your room or are you eating socially with your family, with your friends? Do you go out to dinner? Ask if they're calorie counting. If they are, how many calories are they having? And do they have a goal for calories? Any compensatory behavior. So run through that list. And ask a menstrual history. Just like with any other like mental health visit, you want to ask about mood and anxiety symptoms. So I would give patients like the PHQ-9 to screen for depression and also hopefully like something like the SCARED, which is a 2-page assessment, a longer assessment for anxiety and goes into different types of anxiety when you compare it to just the GAD-7, which is just for generalized anxiety. Ask about trauma or abuse history, since that's very common, and a family history of eating disorders and of other mental health conditions. Going through the physical symptoms. So the symptoms on the left are red flags where the patient might need to go to the ER or needs to have a medical evaluation. If they've been feeling faint or ever fainted, chest pain, palpitations, shortness of breath, and throwing up blood. So I would definitely like screen for these if you're seeing somebody you think has an eating disorder. These other symptoms on the right, these are super common in people who have eating disorders. Fatigue, just chronically, emotional fatigue, physical fatigue. Maybe they are not doing as well in their sports as they used to, or not even participating in those sports anymore. And sometimes patients are going to bed super early too, because they're so tired and also because they don't want to be awake and hungry. It's kind of like a way to avoid eating. Constipation, not eating right, not getting enough bulk in your GI system, not getting enough calories, or eating and throwing up, that really messes up your GI motility. So it's very common to have just chronic constipation. And that can make someone feel even more uncomfortable because they might be more sensitive to this feeling of bloating that they're having. Nausea, reflux, especially for patients who are throwing up, but even just chronic starvation causes reflux, and especially the person is depending on stuff like coffee to suppress appetite, or smoking cigarettes or vaping, that's going to make reflux more likely. Feeling cold all the time, that's from malnutrition. For the physical exam, ideally, we'd want to have a post-void weight in a gown. So that's for someone who has, let's say, anorexia, and you really want to see what their weight is. This is the best way to do it accurately. But I know might not be feasible in all primary care settings. So, do what you can to try to get an accurate weight. But the reason that we want to do this is that if they void first, that at least takes away some effect of any water loading that's going on. And then you can dip that urine, because if the urine comes back and has a spec grab of like 1005, so super dilute urine, you're going to be worried that they're water loading. Consider not sharing the weight. So this varies from provider to provider about what people like to do. I was managing patients with eating disorders in a setting where we had a dietitian on site that specialized in eating disorders. So I defer to her judgment about when was a good time to share the weight. In general, in the beginning of treatment, when your primary focus is just getting food into the patient so that they're able to have a working brain, at that point, it's not really helpful to share the weight, because it doesn't add anything to our treatment when they're already trying to just follow a meal plan. If anything, it could actually make them go backwards a little bit. But later down the road, when they are getting better and gaining weight, and maybe they are more able to think about things rationally, then at that point, you might be ready to share the weight with them. This chart shows severity of malnutrition versus patient's BMI over the median BMI for their gender and age, and also compared to body mass lost in 1 year. So you can get just kind of a general sense of where the malnutrition is. Check orthostatics on them, and then a temperature. Signs of malnutrition on exam, you might see baggy clothes because the person grew out of their clothes, or grew, whatever you want to say. Their clothes are too big for them now, or because they might be trying to disguise how much weight they've lost, or because of the kind of this body dysmorphia where you feel like you're bigger than you really are, so your clothes are bigger. The patient might look wasted, just kind of a look of despair, of fatigue, dried yellow skin, dry thin hair, cold extremities, and then edema. That can be a sign of cardiac dysfunction. You might see signs of purging on exam. Just because you don't doesn't mean it's not going on. You might see parotid gland enlargement, and that can happen. Like if someone has been purging a lot over a weekend and you see them on a Monday, maybe you might see this enlargement. Or chronically, people can have it who are just chronically purging, but swelling in the face. Russell sign is when there's like redness or calluses, abrasions on the knuckles of the hand that you're using to make yourself throw up. People use all kinds of stuff to make themselves throw up. And eventually, if someone's been throwing up chronically, they don't even need anything else to help them. So, not seeing this doesn't mean anything. For most patients with an eating disorder, you're going to end up getting labs. But it's so important to tell the family that the labs are probably going to be normal. And that does not mean that everything is fine. In fact, patients even in the hospital with an eating disorder can have totally normal labs. So we don't want the family to walk away and be like, yeah, well, they checked her and everything was fine. So, okay. So definitely need to inform them about that. CBC, you could see anemia, you could see a low white blood cell count due to malnutrition. On CMP, you can have a lot of just mild abnormalities. You might see an elevation in ALT and AST, that's pretty common. Disruptions in electrolytes if someone has been throwing up or using laxatives. Amylase and lipase, you could consider sending that if someone has been throwing up or having abdominal pain, abdominal symptoms, or maybe they're denying eating disorder symptoms. MAG, FOS, I would say for someone who has significant malnutrition and weight loss. Consider a workup for irregular periods if they are presenting with them, just to make sure we're not missing another reason for the patient to have oligomenorrhea or amenorrhea. Saying that it's due to the eating disorder, it's kind of like a diagnosis of exclusion. Check thyroids. Patients can have a sick euthyroid syndrome where maybe like TSH is low, T4 is low, they're both slightly low. And then sometimes it's mistaken to be, oh, this patient has hypothyroidism. Oh, this patient needs thyroid hormone, where the patient needs food. It's like the patient is not, the malnutrition is so significant that the body is not even producing these hormones. So once the person ends up eating enough, then you'll see a normalization of those labs. Check a pregnancy test on all teenagers who have irregular periods, no matter what, even if they are not sexually active. If anybody ever says like, you know, why would you still do that? Well, I do this on everybody. This is our clinic policy. It's not because I don't believe you, but you definitely need to do that automatically. Urine dip, I mentioned. EKG, you know, if someone has a lot of purging or has significant malnutrition, you would want to check that. DEXA scan, you know, there's a lot of different opinions about what to do and when to do a DEXA scan. For me personally, I think like, what are we going to get out of it? What will we end up doing differently if we know that there is some bone density loss? And we know if a patient has dropped periods, especially, and is chronically malnourished, I will bet you that they have weaker bones. And I'll talk to them about that, and that the best treatment in order to help make your bones strong is eating. It's not with supplementation. It's going to be with actually eating nutritional foods. So if that wouldn't really change or shift, this is a very expensive test to do, and sometimes even can be hard to access. But it might make clinical sense maybe if someone has had, let's say, a dropped period for 6 or probably more like 12 months, you could consider doing that. And it might be a way of illustrating to the family how serious this is. Like, these are the bones you're going to have the rest of your life. Like, you stop making those bones in your 20s, and that's what you got. So let's really try to make sure that we can set you up so that you're not going to end up being, you know, fracturing a hip when you're 80 or breaking a bone right now when you're playing soccer. So think about sending patients to a higher level of care if they have severe malnutrition, physiologic instability. So their, let's say their blood pressure is low, or their heart rate, the resting heart rate is under 50. Patients who are athletes, like who are long distance runners, they're going to tend to have a lower resting heart rate. So we've seen patients, you know, normally with heart rate maybe in their 50s. So when you have a patient who's an athlete on top of restricting, then it can sometimes be complicated to figure out like what is what. But if you have a resting heart rate that's dropping below 50, they need to be evaluated. And then also if they're orthostatic. Growth arrest. So the patient has been like slowly there. If you're looking at their growth chart, their height has been maybe dropping interval or percentiles on the growth chart. Acute food refusal. Patients who are saying, I'm not eating, you can't make me, I'm done. They need to go to the emergency room. Uncontrollable binging and purging. So what can we do as PCPs when we think that someone has an eating disorder? Well, you came to the right place. So there's a lot we can do. The most important thing we do, if there's one thing we do, it's to relay how seriously concerned we are, to talk about how I think you have an eating disorder, and I'm very worried about your physical health and about your mental health. And you can, if the periods have been messed up, you can use that to illustrate this point. So the fact that your periods have gone away means that your body feels like it's in such danger that if you were to get pregnant, it would be very dangerous for the baby and for you. So that's why it's shut down your periods. Like it thinks that you're experiencing like a famine or a war. And talk about in terms of mental health, that when you're so malnourished, your body can't even make the hormones that make you feel good. Like it's impossible to feel happy and relaxed when your body is not getting the nutrition that it needs. Go through the medical complications as well, very frankly. So anorexia, the complications of it are heart failure. Your heart is a muscle. It has to pump constantly. And if it doesn't have enough nutrition, it begins to get floppy and weak and eventually fails. Fractures, talk about bone density, and especially for athletes and how they might end up on the sidelines because of their breaking a bone. Kidney failure, hair and skin issues, dry hair, dry skin. This might be what ends up making somebody start to kind of consider changing or trying to change or engaging in treatment, is something like that, is noticing like my hair is so dry. Like I now I see when I don't want this anymore. And effect on periods. I know people sometimes ask, like, does this mean she's gonna have trouble getting pregnant when she's older? No. If someone's nutrition is reset, we would expect the menstrual cycle to come back again. And in fact, that's such a good sign that now the patient is nutritionally replete. So this won't affect their future fertility as long as, we can work on the nutrition. And mortality rate is 5 to 7%. So this is a deadly disease. For bulimia, patients risk arrhythmia. So I could explain to patients, like if you're throwing up, you end up messing up your electrolytes, like your potassium level. And so that can sometimes cause your heart to beat irregularly. And sometimes it can actually beat so irregularly, you can have a heart attack and it can kill you. And this is why also, if we check the labs and the potassium is normal, it means nothing. It's like you could 1 hour later, we could check it and it could be abnormal. Heart failure, esophageal rupture. So I would say to patients is that the acid in your stomach is so powerful. It's like those YouTube videos where you see it, like it can almost like melt a Coke can. That's what dissolves food. So that acid is not meant to be in these delicate tissues of your neck and in your mouth, and it damages them. So when you're throwing up, that acid over and over again, it can end up ripping a hole or a slit in the side and end up bleeding into your throat, or it can rip a hole, and then that can be deadly. Also, that acid in your mouth ends up causing tooth staining, decay. Patients you could need like multiple root canals, crowns, ulcers also in your stomach from it, causing stomach aches. And the mortality rate of bulimia is 1%. We want to hopefully help the patient identify how the eating disorder is negatively affecting their life. So kind of like in this framework of motivational interviewing, where we don't want to come to the patient as like, this, like, this is what I think. Like coming to the patient instead with concern and educating the patient about the risks of what's going on. And then hopefully the patient can at least notice, like, yeah, I don't like this part of what's going on. I don't like having to miss out on my social life. I do miss that. And that's going to be their first step. And so then also this helps when the family is at home and maybe the patient is like fearful or doesn't want to do something. It can help be a tool for the family to remind the person, like, what about hanging out with your friends? Like, this is why you want to get better. So we can also tell the family, like, taking the first step to feeling better is so scary, but I'm so proud of you. You took this first step today. I know this was very difficult talking about all this stuff, but full recovery is absolutely possible. I've seen many other patients come through here and with similar situations going on, and I've seen them feel better. Also, talk to them about the internet. I can guarantee you that the patient's already seen online and in social media some of these sites and I guess influencers who can perpetuate eating disorders and even advocate for them as like, this is my body and this is what I want to do. And here's some strategies on how you can do it and hide it. So I would encourage staying away from those. Maybe you could even phrase it as like an experiment, or asking, have you seen any of this? But then what do you think about maybe trying to stay away from them for a while and just seeing what happens as an experiment? And then you can also recommend that patients go instead to these other websites, and these can be helpful for families too. Families need our support in what to do when they go home and how to handle the situation. So here are some for you there. Okay, so what do we want to do then in terms of treatment? Immediately, our goals are weight and nutritional restoration for the patient who's lost weight, and stop purging. So for purging can cause immediate deadly harm potentially. So we want them to stop that, or at least really cut back on it. And then in the long term, we'll get to our other goals. So normalizing menstruation, improving body image, and eventually being able to eat in public with friends and family and enjoy it, and not to be worried about what you're eating constantly. Families need to make sure that the patient is eating 3 meals a day. So these recommendations are like in terms of meals. I'm not a dietitian, like PCPs aren't. But if we don't have a dietitian on hand to talk to the patient, we need to give our own kind of just basic nutritional recommendations. And so for me, I would say like she has to be having 3 meals a day, and each meal has to have a protein, a fat, and a carbohydrate. And that's like the bare minimum that somebody could be doing on their own to be able to stay on an outpatient basis. And if someone is not able to do this, then they need more support, whether it's like, if they're not seeing a dietitian, they need to see one. If they're not seeing a counselor, they got to see one. And if they're already engaged in treatment, then they might need a higher level of care. When patients have those meals, hopefully we want them to be together, and we don't want anybody talking about calories, this, that, and the other. We just want the patient to be eating the food. And the family is so important, especially if we're talking about somebody with anorexia that we're just trying to get this food in. They need to enforce this minimum of food. If someone's purging, we want to reduce the harm of it. So patients should not have bathroom privileges after meals, like 30 minutes at least, maybe even more, like 45, 60 minutes. They need to stay away from the bathroom. And that can be so uncomfortable and anxiety provoking for people. So have a game plan. Think about, what are you going to do to distract her while this is going on, or distract yourself while this is going on? Could you guys go on a walk together? Can you play with your dog on the floor? Can you read a book? Can you watch videos? Like, do anything, but just stay away from the bathroom. Rinse with water after you purge, and so don't brush your teeth. Brushing your teeth seems like a good idea, but it's actually the worst thing you can do because it ends up eroding your enamel then even more. And then patients should see a dentist too. Also, think about if they need exercise restrictions, because as PCPs, that can fall under us. Okay, so if someone has lost a lot of weight and they've got anorexia, we need to think about, should they even be in PE? Maybe not. And also, are they in any organized sports? Because you might say, this is too dangerous. And not only that, it's like burning more calories and you're not getting in enough calories. So we need to put those on hold until you are eating, 3 meals a day, and until your weights are stable or you reach your goal weight or whatever endpoint you have. Ideally, the treatment team would include a dietitian with expertise in eating disorders. I know that is so hard to find. I don't know what the situation is in your clinic network, but since COVID, so many more people have needed treatment, and it's increasingly harder to find, especially if someone carries public insurance or has no insurance. But dietitians are valuable because they can put together meal plans for the patient and also help you with weight goals. And they can also help even with kind of like exposure treatment where they're eating together in their office socially. You need a therapist with ED expertise as well. Both of these providers need to have expertise and experience in eating disorders, because if they don't, or somebody say something? If they don't, it can really backfire. So especially, let's say if a dietitian or therapist is used to working with patients who are, trying to lose weight, and then they might end up using some of those like signals or values in the wrong place with your patient. Psychiatry might be indicated, especially, obviously, if somebody's going to a higher level of care, they're going to have psychiatry input, but so much of this can be managed in a PCP office. We are able to prescribe common medications that people use in eating disorders, and also we're able to manage a lot of the medical complications, monitor weight. So this is something that usually should be within our purveyance. I put some resources here where you can try to find providers that are affiliated with like an eating disorder organization, and also free or low cost support and support groups that are online. Eating Recovery Center, that's a privately owned company that I don't have stock in, but they are a nationwide organization, and they have free online support groups for patients and families. And I see there's a question here. The question is, could you please speak to best practices for discussing weight or BMI, physical activity, and nutrition in the exam room for all patients? Some patients with EDs identify a particular interaction with the medical provider as a potential trigger for their disordered eating. Okay, so Jocelyn, that's such an awesome question. And I think you're talking about patients like maybe that you're not considering to have an eating disorder, and that you're trying to do general counseling on nutrition. Is that correct? For patients in that scenario, what I say is, oh, okay, she said yes. Okay, so I would talk about how, in terms of eating patterns, like I think it's really important to give your body what it needs in order to have a like for healthy body and healthy, I'm sorry. Let me start over. Okay, so I like to focus on giving your body what it needs for a healthy body and a healthy mind. And I don't care at all what someone's weight is on the scale. That's not to say that maybe, of course, the patients have a BMI that's well above average. That makes me wonder maybe if the nutrition that they're getting is not aligned with their body's needs. But what I tell patients is what I care the most about is just that you're giving your body what it needs and listening to your body's signals about hunger and fullness. And I also tell patients, I say this to everybody because I don't want someone to think I'm singling them out when I'm not. I say this to literally everybody. And so giving your body what it needs to me means a lot of fruits and vegetables, a lot of home cooked food, or as much as home cooked food as possible, with real world ingredients. And that's important because it has like the vitamins and the nutrients that your body needs, but also because that type of food makes you feel good and it makes you feel like you're full, as opposed to eating like prepackaged something, ramen, and then like an hour later, you're like, oh, I'm hungry again. So as much like real food as possible. And then listening to your body signals about hunger and fullness. So trying to eat when we're reasonably hungry, and then trying to not eat when we're not hungry. So listening to ourselves, like if I want to sit down and eat a bag of chips, am I really hungry? Or am I eating because of one of the other million reasons that we all eat, like happiness, boredom, sadness, it's sitting there. So hopefully it's because like I want to eat something. And if it's not, then go do something else, like drink water if you're actually thirsty, or if you're sad, talk to somebody about it. But then when we start to eat it and enjoy it and sit down and look at it. And instead of, sometimes I think when people are feeling guilty about what they're eating. They eat standing up, they hurry up, they eat it fast. It's like, that's not even enjoyable. I want you as my patient, I want you to enjoy what you're eating. And if we eat kind of like mindlessly, like watching TV, all of a sudden you're like, wait, where did that bag of chips go? I didn't even enjoy it. I don't even remember I ate it. And so we want to enjoy it. So these are, I think focusing on that can be helpful. And then as we're eating, pay attention to your body. Am I getting full right now? Okay, when I'm starting to get full, like this is a point I want to stop, because I know if I keep going, it's like the food is not even pleasurable anymore. Also, I think I talk to patients about there's no bad food. Nothing is bad. Nothing is good. Nothing is clean. I hate that term, clean eating. I swear, it's like triggers me. Clean eating, because what is clean? What does that mean? So there's no food that you should say, I won't have it. Like no carbs, because our bodies need carbs for energy and so that we can pay attention in class. So anytime that someone is kind of doing something restrictive like that, I think that's not healthy. Plus, if we cut things out, like no desserts, no chocolate, I'm not eating any chocolate. Okay, so for 2 weeks straight, no chocolate. I am thinking about chocolate. Oh my God, chocolate. And then finally at the 2-week mark, I don't eat just one candy bar. I'm gonna eat like 5 because I really miss chocolate. And do we really want to not eat chocolate the rest of our lives? So whatever patients do for changes in their nutrition or in exercise needs to be for a lifetime. It needs to be sustainable. So stressing sustainable changes, what can you do the rest of your life instead of quick fix yo-yos? Patients who are yo-yoing all over the place, dieting, you notice their ways up and down. We have to talk to them about that, because it is a miserable place to be when you restrict something so much, but then, okay, well, yeah, I really dropped all this weight, but then I miss all that food and I need that type of food. So then the weight comes back on and now you have even a slower metabolism. So it's much better to try to do things that you can do for the rest of your life. And in the end, all we care about is like what they're actually putting in their body, not what, I don't care about your numbers. I don't care about weight loss. No, we should not be talking about losing 5 pounds or you should lose this amount of weight. I don't think to any teenager. Okay, so I hope that like verbal diarrhea answered your question. Okay, so let me finish this up here. Okay, so this is a very important slide. The treatment of an eating disorder, especially of restrictive eating disorder, is food, food, food. It is food. They need food. Nothing can replace food. By eating food, this is how we can reverse all of these potential negative effects from restricting. They will start making serotonin again. They will start making thyroid hormone again. They'll be able to concentrate. They'll be able to understand. They'll be able to cope better with stress. It is food. And so that's why the treatment regimen for anorexia involves families, because families need to say, this is a life or death situation. You're going to eat this. And if you're not able to eat it, what I'm putting in front of you, then you're going to have to go into a higher level of care. Multivitamin, vitamin D, calcium, great, sure. You can add that, Dr. Cohen. I don't know if you have another opinion as a pediatric endo, but I mean, sure, it's not going to hurt anybody, but it's not the same benefit as in food. And we don't want people to think like, oh, I'm just going to take a vitamin. This is going to substitute for eating. There's no role for OCPs unless the person's sexually active and obviously they need protection against pregnancy. We don't want to prescribe birth control pills to someone who has an eating disorder and irregular periods, because it's going to end up messing up. It's going to interfere with them using the period as like a vital sign, because it's going to artificially make their periods come regularly. And then sometimes families can have a false sense of like reassurance, like, okay, but she's getting her period again, so like all is good, but it's not. We want to be able to know when the body is bringing back the period, because then that's a good sign that they're nutritionally repleted. And then, and also in terms of bone density, the data I've seen is that unfortunately it doesn't seem to work to help improve bone density in patients, in adolescents. And then no laxatives. patients are going to ask about, what can I do? I'm so constipated. Food is the best way to help reset people's GI motility. And if someone is very uncomfortable and they haven't pooped in like days, you might consider like a non-stimulant laxative, not a laxative, something like, maybe like a little bit of Miralax, Colace or something, but definitely stay away from stimulant laxatives. And then also if you do use anything, use it very judiciously. So anorexia, the treatment involves family-based treatment and then possibly an SSRI if the patient has like persistent anxiety, OCD, or depression. But keep in mind that if you have anorexia, you're not even making serotonin for the SSRI to work on. So it's not going to help. SSRIs are not indicated to treat anorexia. We might want to use it if, let's say, the person has anorexia and a bunch of other anxiety disorders going on, although it might not even work. Or let's say they've been weight repleted, but they still have disordered eating, but they have this persistent anxiety or OCD. Fluoxetine is indicated for the treatment of bulimia in adults, but really the foundation of treatment for both of these is going to be that family-based treatment, where not figuring out like you did this and you created this, but more like how does the family get involved and just create an environment for the patient to get better. Binge eating, CBT or IPT might be helpful. And then ARFID, it seems like cognitive behavioral therapy is the way to go. And you'd want to make sure that the therapist uses that and not some other form of like talk therapy. So for recovery, as patients get better, usually the first step is that they start to just notice that what Ed's voice is. Like when they have thoughts about like, I'm fat, like I should not, oh my God, I can't eat that. That's bad. Oh, that's Ed talking. That's my eating disorder talking. And then eventually you start disobeying Ed, where even though Ed's saying it, and I really want to not do this, I'm still going to eat that. I'm still going to eat that Reese's Pieces. I'm going to do it. Or still, I'm just not going to go to the bathroom. And like the more you disobey him, the quieter that voice gets over time. So this is like a foundation of CBT, is where your actions are going to end up influencing your thoughts and your feelings. Prognosis, half improve significantly, a quarter do poorly, quarter in the intermediate zone. Recurrences are so common. So if you have a patient with an eating disorder, we want to be like on the lookout for anything that suggests that maybe the patient is like taking a step back again. Like maybe it's involved with like going off to college, some other stressful event. And that can be so demoralizing for somebody where you're like, I thought I was doing better. Here we go. It's over. I can't. So we really want to provide support for that patient. So Jenny Schaefer said, alcoholics can never drink again, but I had to eat again every day, many times a day for the rest of my life. And she says that's how she knew she was fully recovered. People with eating disorders, food all around them all day. Very, very hard. You look at yourself in the mirror every day, probably. So this is something that can be very difficult to extract yourself from, but it's absolutely possible. Oh man, I had these cases too. Okay, so sorry, we're totally up at the limit. I talked too much. Does anybody have any questions?
Thank you, Dr. Musacchio, for this wonderful talk that's given clinicians a lot of tools for treating eating disorders. Dr. Musacchio recently won the MAVEN Project Educator of the Year Award, and I can see why. So we are at the top of the hour. Does anyone have any questions? And if not,
sorry. I was going to say too, you can also send me consults or questions about cases through MAVEN. You can send them directly to me. I'm under the eating disorder section or under behavioral health too. So please, I welcome them.
oh, there are some questions. Oh, how often do you monitor patients with eating disorders in your clinic? The follow-up visit timing?
It really depends on how serious it is, what's going on with them mentally, physically. So that's hard to say. But I would say my bias would be towards more closely in the beginning because I'm going to assume I don't really know everything going on. So I want to kind of get a better handle and understanding on the situation before I would have them come back later.
Any other immediate questions? Okay, well, if not, we're at the top of the hour, so I'm going to stop recording. And thanks again, Dr. Musacchio, very much. And as she said, please send your consults to Maven. We love to help.
Thank you,
Okay.
everybody. Thanks. Bye.
Bye-bye.